Thank you very much. Hola, that's one of the two words I have for in Portuguese. Well, it's a great pleasure to be here with you and to talk and share some information about one point which is always a difficulty sometimes, the airway. This is my disclosures. We'll focus on these 3 points. So the agenda of the talk will be special issues related to the emergency airway management. I will remind you some basic airway management techniques, and we'll focus at the end with the advanced airway management. So, tracheal intubation in the emergency setting is quite difficult, and this is a very old paper published in Anestesiologia in 1995. As you see, the complications of tracheal intubation were quite high. If you look to the usual difficulty incidence in the scheduled surgery, it's very less than 4%. And there you see that difficult intubation or esophageal intubation is 8% both, which means 16%, and you see that the mortality related to tracheal intubation was, in that study, nearly 3%. So, is emergency a risk factor for difficult airway? Yes, and I will show you how and why. This is a paper published by a colleague of mine, performing and rating the difficulty of tracheal intubation. This is the intubation difficulty scale, the IDS. You've got several items, the number of applicants, number of operator, the COPA grade, and so on, and you just score the difficulty. If the score is above 5, the tracheal intubation is set to moderate to major difficult. What did they observe in their study? They observed that above a threshold of 5 on the IDs, the difficulty was accounted in 6% of the cases for scheduled surgery and 16% in case of emergency. So it's 3 times more frequent in emergency than in scheduled surgery. A very important paper, and for the youngest people in the audience, I would recommend to read this. This is the NEP4 study published in the BGA in 2011, and they related the complication about the airway management either in anesthesia but also in ICU and emergency department. There were about 184 cases of difficulties in anesthesia, 133, emergency, ICU. And what can we observe in this report? We observe that ICU and emergency department, it's 28% of all events, but nearly 60% of the deaths of brain dead. So few events, but lots of deaths. In contrast, during the anesthesia setting, it's nearly 3/4 of the cases of the events. It's still 41% of the deaths, but much less than in the emergency cases. So for sure, we have to make a huge progress in emergency, either in emergency department and ICU, to decrease the mortality related to the airway management. And when you look to the causes related to the difficulty in emergency department, you observe the number of cases of failed aspiration, failed intubation with esophageal intubation, CICV, cannot intubate, cannot ventilate, iatrogenic, and difficult or delayed intubation. So there are sometimes, and quite a lot of time, difficulty of the airway management, but also of oxygenation in these cases of emergency. Another point is the prediction of the difficult airway. In emergency, it's for sure much more difficult than in scheduled surgery. So it gave you no satisfaction, but in case of head or neck trauma, you may expect more difficulties than in scheduled surgery because of the edema of hematoma. So in this clinical setting, head or neck trauma, beware to perform tracheal intubation sooner, much sooner than too later. So the basic airway management is one of the following items. You should perform the airway patency. In case of trauma, you should immobilize the cervical spine. Sometimes, even if you perform usually a rapid sequence induction without mass ventilation. Mass ventilation is mandatory in case of oxygen desaturation, so you should use oral or nasal cannula, even sometimes transtracheal intubation, transtracheal oxygenation, and tracheal intubation. So you must have algorithm. Algorithm, it's a plan to perform with a predefined strategy to implement some techniques, including the anesthesia with a rapid sequence intubation. So you have so many devices to perform tracheal intubation on oxygenation. But you should take the good device for the good patient at the right time. So just to remind you some basic airway management, chin lift, jaw thrust, pre-oxygenation is really, really important. It's a life insurance of your patient during the tracheal airway management to avoid oxygen desaturation. Pulmonary regurgitation prevention with the Selic maneuver, which, remind you, was published more than 55 years ago in cadavers. This is the original picture from Sir Brian Selic, published in the Lancet. And also a very important point is to limit the tracheal intubation attempt to 3, but not more. And I will show you why after. These slides show you the oxygen desaturation below the threshold of 90% of SpO2 according to the clinical status of the patient. For a normal 70 kilos adult, you may observe this oxygen desaturation after 8 minutes after the induction. But when you get an obese patient, like this case with 127 kilos, its oxygen desaturation occur before 3 minutes time. So in emergency, like the obese patient, sometimes you may observe a decrease of the functional respiratory capacity. And this decrease of the FSC is the decrease of the oxygen stock during pre-oxygenation. That's why pre-oxygenation in that case is really crucial. And pre-oxygenation allows you to buy time to perform tracheal intubation. And this is the way it could be life-saving technique. You just buy time. And if the patient is already hypoxic before tracheal intubation, this is a nice study published in 2006, and they performed 2 groups in this randomized study. The first group was here in black dot with spontaneous ventilation with 15 liters of oxygen in oxygen flow. And the second group, it's a pressure support group with pressure support enabling 7 to 10 milliliters per kilo of tidal volume. And what do you observe on this slide? You observe that in the spontaneous ventilation group, you have a huge decrease of the SpO2. And in contrast with the NIV group, you maintain the SpO2 always above the 90% of SpO2. And when you look to the minimal SpO2 during the tracheal intubation, you see the NIV is always, for the most of the cases, above or just beside 90%. But in the control group, you may observe huge desaturation, ending to 50%, and that's a very difficult case. So when the patient is already hypoxic, prefer NIV for pre-oxygenation. Okay, this slide just to remind you in case of spine injury to perform tracheal intubation with the manual inline stabilization maneuver with the provider of tracheal intubation. the help with the tracheal tube, the Selic maneuver, and another guy or girl maintaining the spine, cervical spine immobilized in the right way. The anesthesia technique is very important. In this paper, they observed, according to the technique of anesthesia, the difficulty of tracheal intubation. This is the RSI with etomidate plus succinylcholine, and they observed 7% of difficulty cases. In contrast, you see with all other techniques, even etomidate alone, you have nearly 50% of difficulty, and with propofol alone, you've observed 8% of difficulty. But in that case, with propofol alone, you pay a lot on the hemodynamic instability if you want really a good anesthesia to perform an easy tracheal intubation. So the anesthesia technique is very important. Another story is this one. One day we observed that the pharmacist gave us a plastic blade. And they say, well, they're very good. Try to use the plastic blade in emergency. And what we observed, that we had lots of difficulty to perform tracheal intubation. So we did a randomized study with a crossover technique of the plastic blade and the metal blade. And what we observed at the first attempt, we had a failure in 17% with the plastic blade in comparison with 3% with the metal blade. And after the second attempt, we just switch, for instance, plastic for metal, and we win a lot of Cormac grade. If the Cormac grade with the plastic was 4, we decreased to 3 or 2 with the metal reusable blade. So the point is, don't make the tracheal intubation more difficult than it should be. Take all the chances on your side. And in that case, for emergency, because it's much more difficult, don't use plastic blade. Use metal blade, reusable or single-use metal blade. I told you that you should limit the tracheal intubation attempt. On this slide, you see that difficult airway could be related to difficult mass ventilation from 0 difficulty to absolute difficulty. Same for laryngoscopy and intubation. But if you have an easy mass ventilation in scheduled surgery at the beginning and a difficult airway with a difficult intubation and laryngoscopy, you may be traumatic, and the mass ventilation could become difficult after say 3 or more attempts. So beware, the emergency is a high-risk situation, and the number of tracheal intubation should be limited below 3. Sometimes you have to oxygen in emergency your patient, and you perform the transtracheal oxygenation with the manual jet ventilation with this device and with this needle. And the point is you have to check the expression, because if you insufflate high flow oxygen in the patient without expiration, what will happen? Well, the patient will explode in a few minutes. So really, really beware of that. And this is the case of on this slide. You may observe that there was a airway obstruction here, insufflation, and the thorax pressure increased a lot, as you see there. And after they relieve the obstruction of the airway, you observe the decrease of the thorax pressure. Last point is the advanced airway management. With LMA, sometimes the fast track, the intubating laryngeal mask, video laryngoscope, cricotomy, and tracheotomy. We'll focus on fast track and video laryngoscope. Sometimes this is a pre-hospital care in France with the SAMU, which is performed by an emergency physician. And this guy was very difficult to tracheal intubate, and they used the fast track to perform tracheal intubation. And in this paper, with very predefined algorithms in case of unanticipated difficult airway in anesthetized patient, they have a plan. The first line of tracheal intubation device was a gum elastic bougie. In case of failure, they used the intubating laryngeal mask airway. And according to this strategy, what did they observe? Well, they had 90% of success with using also sometimes the gum elastic bougie. And in case of failure, they had 7 cases with the rescue with the airway for tracheal intubation, and 2 other cases, so 2%, they performed not tracheal intubation, but they oxygen the patient through the airway. So in 100 of the cases, the oxygenation was performed and the patient were alive. That's a very important point. This paper performed in emergency department comparing the standard laryngoscopy and the glide scope, which is one of the most popular video laryngoscope. They don't see any difference between the 2 techniques in the overall success rate. What did they observe? They observed that the glide scope at the first attempt was more successful than the standard laryngoscopy. And this was really true in blunt trauma patients and not so true in penetrating trauma patients. If you are faster to perform tracheal intubation in emergency, you may decrease the complication like esophageal intubation and oxygen desaturation. This was the case in that study with the glide scope. They decreased the difficult airway and decreased, which is very important, the number of oxygen desaturation. In France, our National Society of Anesthesiology performed also algorithms. This is one of the algorithms we have in case of unanticipated difficult intubation. You may observe that the key issue is the mask ventilation. If it's efficient, you perform laryngoscopy, only 2 trials, and sometime that will be implemented, you may have video laryngoscope. In case of difficulty of mask ventilation, you have to perform oxygenation with the intubation laryngeal mask, and if it's efficient, you perform intubation, and inefficient, you may have invasive oxygenation techniques. So to conclude, I hope I convinced you that emergency make the airway management much more difficult. So a strategy arising from guidelines and algorithms are really important, and they are always the first step to solve a difficult airway. And the key issue is maintenance of oxygenation. And this guy, you know him. If you don't know him, you heard the story. He just landed on the Hudson River. He had a plan. So my question is, for the difficult airway, do you have a plan? Obrigado.